Hello, everybody, on this Monday afternoon. Great to have all of you with us for Grand Rounds. Delighted to welcome our special guest all the way from Uptown today, Dr. Adam Morgenthau, who's the director of the Sarcoidosis program here at Mount Sinai. Is a sarcoidologist caring for about 800 sarcoidosis patients, both directly and by supervising the fellows in their practice. He's been involved in clinical trials, in writing a Thoracic Society clinical practice guideline, and we are really excited to have him with us today talking about the many faces of sarcoidosis. Take it away.
Thank you, Dr. Weissman. Thank you, everybody. Very nice to be here. I appreciate the department's invitation. I've been doing this for just about 20 years now, so very passionate about sarcoidosis and hope to convey that passion to you today, and along the way, hopefully you learn something as well. So I do not have any conflicts of interest. So I'm going to start off today by just giving a little bit of background, making sure that everybody's on the same page, and provide a few updates as to regard to risk factors and clinical manifestations and things of that nature. Then touch on a slide or two related to phenotyping. You can't discuss any rheumatologic or immunologic disease without mentioning biomarkers. I'll then transition to clinical vignettes, really to illustrate two important questions that inevitably come up in dealing with sarcoidosis patients. The next group of slides will really cover immunopathogenesis and new therapeutic targets. And I'll end with a slide or two on drug-induced sarcoidosis, and then conclude, and hopefully there'll be a lot of questions. So as many of you know, sarcoidosis is a worldwide disease. It's present in individuals of all ages and races all over the continent. And you can see on the left cartoon here that the prevalence of sarcoidosis is highest in the US. In African-American women, about 18, the incidence, about 18 per 100,000 individuals per year. But it's also very common in other countries, specifically Scandinavia. And the sarcoidosis that they see there is a bit different than the sarcoidosis we see here, but it is a worldwide disease. The interesting thing about sarcoidosis incidence and prevalence is that there's this peak age of onset around 50 years old. But for reasons that are not completely understood, but probably have to do with genetics, men tend to present earlier than women. Usually men present in sort of the 30 to 50 year range, whereas women present initially onset at around 50 to 60 years of age. And this finding is sort of independent of location. You can see on the table on the right, which is showing three separate graphs of incidence per 100,000 per year at various age groups, that in Minneapolis, in Korea, in Sweden, the peak age of onset is always earlier in men than it is in women. So there are a number of risk factors for sarcoidosis, but one of the risk factors that was appreciated more recently than some of the well-known risk factors are that obesity and weight gain are associated with sarcoidosis. This is data that comes from the Black Women's Health Study, which was conducted, it was a prospective study conducted of 59,000 patients. And if you look at the various tables here, you can see that sarcoidosis risk is associated with a BMI that's high at age 18 years of age, and that with weight gain, the risk increases. So clearly, obesity and weight gain are risk factors for sarcoidosis, which wasn't really appreciated about 10 to 15 years ago. We've known for a long time that genetic factors influence disease susceptibility in sarcoidosis. And we know that certain genes carry more weight than others, and we know that genes interact with each other, and it's the interaction or the gene product that sort of influences sarcoidosis risk. We also know that that first-degree relatives of sarcoidosis patients have a 3 to 5 times higher risk of developing sarcoid compared to the normal population. But what we've learned over the past 10 or 15 years is really that sarcoidosis doesn't really happen unless there's a relevant exposure. And that exposure, has an influence on the manifestation of the disease. It's really sort of the duration of the exposure, the intensity of the exposure, the timing, and the context of the exposure, in addition to the predisposed genotype that influence the outcome of disease. And you can see here that there are a number of alleles that affect sarcoidosis risk, but the HLA alleles are most strongly implicated in sarcoidosis disease susceptibility. The HLA alleles are also influence the clinical presentation and the disease course. And this is just a chart that comes from a review that looked at various HLA alleles. And you can see just by skimming it very quickly that there are various alleles that are associated with a very good prognosis, perhaps even acute sarcoidosis, Lofgren syndrome, and acute which has a very good prognosis, or other HLA alleles that are associated with prolonged disease or chronic disease and have a less favorable prognosis. So genetics plays an important role in the clinical presentation and disease course. We sort of got an inkling about genetics and understanding disease manifestations from a very important study that was conducted in the 1990s called the ACCESS study. ACCESS is an acronym for a case-controlled etiology study of sarcoidosis. And ACCESS was conducted at 12 centers throughout the United States, 700 cases, 700 controls, matched by age, gender, and race. And really the point of the study was to answer two questions. Is sarcoidosis risk associated with certain occupational or environmental exposures? And are the clinical manifestations of sarcoidosis associated with age, gender, and race? So for the time being, I'm going to answer the first question, and then a little bit later, we'll talk about the second question. But as you can see here from these data, there were a variety of exposures associated with sarcoidosis risk. But if you look at these odds ratios, all in the 1.2 to 1.5 range, the odds ratios are pretty low, and they're less than 2, and usually less than 2 is, not very significant. And what this really says to us is that, these exposures are implicated in sarcoidosis risk, but they're not transformative, they're not causative, they're not driving the risk entirely. And this was a surprise to investigators because investigators really felt that there would be one predominant etiologic exposure that would be associated with sarcoidosis risk. And it turns out that there are many different exposures that are modestly associated with sarcoidosis risk. Later studies have looked at other exposures that are associated with sarcoidosis risk, in particular exposure to World Trade Center dust and debris. And there have been another number of studies that have looked at exposure to World Trade Center dust and debris. And for instance, if we look at a study done by Izbiki in 2007, the incidence of sarcoidosis in those who were exposed to the debris was 22 per 100,000 per year. A subsequent study by Crawley showed that the incidence was 34 per 100,000 individuals per year. Just to give you some context, the US disease incidence of sarcoidosis is somewhere around 8 per 100,000 per year. So exposure to World Trade Center dust and debris is associated with increased sarcoidosis incidence. But it turns out that when you dig deep down into that relationship, you understand that patients who were exposed to World Trade Center debris, not all of them develop sarcoidosis. And the reason is because, as I alluded to before, the timing, the context, the severity, the duration of exposure are implicated in developing the disease. And you can see here that not every patient who was a passerby in the World Trade Center dust cloud developed sarcoidosis. The highest risk of developing sarcoidosis were for those people who worked on the debris pile. And you can see that the odds ratio was 9.1. So you really had to have a severe sort of intense exposure to the debris to really have a strong risk of developing sarcoidosis. Sarcoidosis is a very phenotypically heterogeneous disease, and I'm going to talk a little bit more about this in the next couple slides. But as a result of the phenotypic heterogeneity, many people have questioned whether part of the reason that the disease is so phenotypically heterogeneous has to do with the different exposures that patients might be exposed to. And an example here is that this is a retrospective study that looked at 238 patients and asked the question, are certain clinical manifestations of sarcoidosis associated with certain exposures? And you can see here that there's pulmonary disease, there's liver disease, there's splenic disease, cardiac disease, and all of those manifestations were to some extent associated with certain exposures with, fairly significant odds ratios. So I think that, this is a start to answer the question that certain clinical manifestations might be associated with certain types of exposures, that you can link those two. But I think an argument against this is that this is a super small study and it's retrospective in nature, and that, larger studies, perhaps prospective studies, are needed to better understand whether this holds true. So I mentioned before that one of the key questions of access, a case-controlled etiology study, was, is sarcoidosis risk associated with certain occupational or environmental exposures? And we talked about that. But the second question was, are the clinical manifestations of sarcoidosis associated with age, gender, and race? And we learned from the access study that indeed, age, gender, and race do affect the clinical manifestations of disease. These are data that was generated from the access study. And you can see on the y-axis, there are various clinical manifestations. You can see on the x-axis, there's the percent of patients involved. And then within this graph, there are three different panels that are characterized according to race, gender, and age. And you can see that certain clinical manifestations are more common in certain individuals, depending on their age, gender, and race. A prime example is hypercalcemia. For example, hypercalcemia is more common in African Americans. It's also more common in males than it is in females. It's also more common in patients who are older than 40 years of age compared to patients who are less than 40 years of age. And there are other clinical manifestations that we can look at in this graph that prove really that the age, gender, and race do affect the clinical manifestations of sarcoid, and it's very important to understand that. So gender and race also affect mortality in sarcoidosis. These are data generated from Jeff Svargus out at National Jewish. This study was done, I think, in 2011, and it discusses the numbers of deaths and age-adjusted mortality rates per 100,000 individuals per year. And on the left y-axis, you can see the number of deaths. On the right y-axis, you can see the mortality rate per 100,000. And there are two graphs. The first graph looks at these data with respect to male versus females. And the second graph really looks at these data according to females of different race. And what's important about these data is that during the period of 1988 to 2007, the number of deaths and the age-adjusted mortality rate was highest in females compared to males. But at the same time, if you look at the the second graph on the right, you can see that the age-adjusted mortality rates were highest among Black females compared to females of other races. And this is really data that supports the concept that sarcoidosis is most severe and most deadly in African American women. Gender and age differences also play a role in clinical manifestations in non-US sarcoidosis patients. So these are 3 different studies from three different regions, one in France, one in Spain, one in Japan. And these are all, discuss incident cases. And what you can see is there are a lot of nuances between, age and gender. For example, in France, older patients, those defined as greater than 65 years or more, are often female, and they have a higher prevalence of ocular and cutaneous disease compared to males. They have a lower prevalence of pulmonary and enodosum and lymphadenopathy. Likewise, in Spain, women are also diagnosed at an older age. We talked about that previously. Higher prevalence of cutaneous and musculoskeletal symptoms, but a lower prevalence of hypercalcemia and renal disease. And then lastly, in Japan, younger patients, less than 40 years of age, tend to have a higher prevalence of bilateral hilar adenopathy and uveitis, and their disease resolution usually occurs in less than 5 years. So it's interesting to see how these age and gender differences play out in different populations throughout the globe. So I've mentioned a couple times throughout the talk that the phenotypic heterogeneity in sarcoidosis is vast. And, this makes caring for patients with sarcoidosis challenging. It also makes it very difficult to enroll similar patients in clinical trials. And it also led people to question as to whether the phenotypic heterogeneity could be accounted for by different occupational and environmental exposures. And we discussed those data a few moments ago. But this is just a slide really to sort of show visually all of the different, or not all, but a large number of the clinical manifestations of sarcoidosis, and how, one might actually question that these are different patients. You can see in the top panel here, that's cobblestoning of the airway on a bronchoscopy. Panel B is a skin lesion on the earlobe. Panel C is sarcoid dactylitis, swelling, an acute inflammatory arthropathy of the hands. Panel D is lupus pernio. Panel E is enhancement in the septum, the cardiac intraventricular septum in a patient with cardiac sarcoidosis. F is, a digit, a finger with cystic bone lesions in the finger. G is skeletal muscle involvement on a PET scan. And H is granulomatous infiltration of a tattoo, which is a very classic cutaneous manifestation of sarcoidosis and something that we see fairly often. And then I is a case of sarcoidosis infiltrating the pituitary gland. So, really a lot to sort of take in with respect to one disease. So there, as everyone probably knows, there are no molecular phenotypes in sarcoidosis. So it becomes very difficult to sort of categorize patients phenotypically. And we do it clinically, and we do okay, but it really poses a challenge for things like clinical trials and understanding patients when we don't have discrete phenotypes. So, one of the ways investigators or researchers have tried to get around this is by looking at different ways to phenotype people through genetic cluster analysis. And this was one study that was done in Europe. It was about 2,100 German sarcoidosis patients. And they basically divided patients up into different phenotypic clusters. There was an abdominal cluster, an ocular, cutaneous, cardiac cluster, a musculoskeletal cutaneous cluster, a pulmonary lymphnodal, a lymphnodal cluster, and then an extrapulmonary cluster. And you can see there were various characteristics that they looked at in each particular cluster. And, for example, the ocular, the cardiac, and cutaneous cluster, 75% of those patients needed therapy. So this is a way of, understanding our complex heterogeneous patients, but it is a bit limited. It's also important to understand that this study, in this study, 60% of subjects were female, 19% were smokers, and all subjects, all 2,100 subjects were white. So this may be an appropriate way of phenotyping a German population of sarcoidosis patients, but not necessarily applicable to US sarcoidosis patients who are much more phenotypically heterogeneous. So these studies have their limitations. So, like I said at the beginning, I've been doing this for, I think, close to 20 years or 20 years. And every year we hear about the question relating to, is there a biomarker for sarcoidosis? When will we find a biomarker for sarcoidosis? We need a biomarker for sarcoidosis. And, before we talk a little bit about those biomarkers, let's just discuss, a sort of agreed upon definition of what a good biomarker is. And a good biomarker is a characteristic that can be objectively measured and evaluated as an indicator of normal biological processes, pathogenic processes, or pharmacologic responses to a therapeutic intervention. And the question is there an adequate biomarker in sarcoidosis? And there are generally two types of, broadly, there are two types of biomarkers. There are chemical or, immunologic type of biomarkers, bloodstream, lymph nodes, fluids of some sort. And then there are other biomarkers like radiologic biomarkers. And many researchers have looked at biomarkers, chemical biomarkers, in a number of different cell types. And all of us are familiar with serum ACE because it's been around for a really long time. And it's a macrophage-derived biomarker. Serum ACE is elevated in about 30 to 80% of sarcoidosis patients, but the sensitivity ranges between 22 and 86%, and the specificity is somewhere between 50 and 95%. So most of you probably know that ACE is really a very poor biomarker for sarcoidosis, and it is certainly not diagnostic of. And can it help you understand certain things about your sarcoidosis patient? Yes. When an ACE is above 100, it's more likely to be associated with sarcoidosis. The ACE level will fall when a patient is taking their immunosuppressive therapy like prednisone. But patients who have active disease can have a normal ACE, and patients who have inactive disease can have an elevated ACE. Universally, patients who have Lofgren or some form of acute sarcoidosis generally have an elevated ACE. But more than that, it's very tough to pin down ACE, and it can only be used in very specific ways and is not an adequate biomarker of disease activity or onset in sarcoidosis. Others have looked at a variety of other biomarkers, and one of the biomarkers that is most often used in sarcoidosis is the the soluble IL-2 receptor antibody biomarker, which is a biomarker of T cell activation. It's nonspecific for sarcoidosis, meaning it's elevated in other conditions. It has a sensitivity of about 88%. It seems to correlate with active disease, but it's important to realize that we have a lot of other tools that we can use to determine whether somebody has active disease. And impaired renal function actually increases soluble IL-2 receptor levels. So you have to be careful in patients who have renal disease. Suffice it to say that serum IL-2 receptor and ACE and all of the other chemical antibodies are really not adequate to serve as a prime time ready to go biomarker of disease onset and activity. And as a result, people continue to look to find biomarkers, to try and find a biomarker that might be useful in sarcoidosis. As I mentioned, there are also radiologic biomarkers, and many have turned to these as of late. For example, there's something called the CT activity score, CTAS. And the CT activity score really looks at nodules, ground glass, opacification, septal thickening, consolidation. And there was one study that showed that the CTAS, you get numbers for each of these and you get a total score. And there was one study that showed that the total score was found to predict response to treatment in FVC after 1 year. And that was in a cohort of about 100 patients. I think, obviously that requires further evaluation. Of course, we also have our cardiac MRI that we use for cardiac sarcoid. We have our myocardial PET scan, which we use for cardiac sarcoid, and we have the PET scan in general, which we use for sarcoidosis. Late gadolinium enhancement on cardiac MRI is prognostic, and we know that that finding late gadolinium enhancement on cardiac MRI is associated with higher risk of cardiac events and mortality. The same is true of FDG and perfusion defects on cardiac PET scan. Those are associated with a higher risk of cardiac events. It's a bit up in the air as to whether FDG uptake in the lungs is really a good biomarker for disease activity in pulmonary sarcoidosis. There are a number of papers that suggest that it's useful to use PET to determine whether pulmonary sarcoidosis is active. I can tell you that my anecdotal experience doesn't sort of match up with this. And I think that the PET has a long way to go in order, from a pulmonary standpoint, to predict both, active disease and to a certain extent response to therapy. I think for cardiac sarcoidosis, the PET scan is a bit better. But basically, we have elements of each radiologic test that is useful for as a biomarker, but no one biomarker that can tell us everything about the disease and its activity or its onset. So in addition to being phenotypically heterogeneous, sarcoidosis has, a very a variable clinical presentation and disease course. And, there's no right way to think about sarcoidosis disease course. We can think about it in terms of type of onset, acute versus non-acute. We can think about it in terms of natural history. Is the disease remitting in less than 2 years? Is it chronically stable? Is it chronically progressive? And we can also talk about sarcoidosis in terms of its organ involvement. Is it pulmonary versus extrapulmonary? Is it fibrotic? Does a patient have high-risk cardiac disease or CNS disease? So this also makes it challenging to think about sarcoidosis from a phenotypic point of view. And of course, we have our scatting stage, and I assume that most of you are familiar with the scatting stage. Scatting stage is a stage of the X-ray. And you can see here that we have our 4 classic scatting stages. The scatting stage on the top is scatting stage 1, which is characterized by bilateral hilar adenopathy. Stage 2 on the top right is bilateral hilar adenopathy and interstitial infiltrates. Stage 3 is interstitial infiltrates only, and that's at the bottom left corner. And then stage 4 is characterized by scarring. And each of these stages has some prognostic significance. That is, if you have a stage 2 X-ray, if you have a stage 1 X-ray, within the first 2 years of diagnosis, you can expect an 80% chance of remission. Whereas if you have and a stage 4 X-ray at 2 years of diagnosis, and your chance of remission is near zero. But just because you have a stage 4 X-ray doesn't mean death is, ensuing. And it's important to point out that X-rays, stages of the X-rays don't necessarily proceed chronologically. And patients with a stage 4 X-ray may hang out for years and not have any change in their pulmonary function. And so I think that, while the scanning stage helps us, it's certainly limited in its ability to tell us, to prognosticate. And it's a limited tool. And just as an added sort of fact, many of you may know that the whole scanning stage was developed so physicians could communicate with one another about what the X-ray actually looked like. It's not really developed as a prognostic kind of tool. I think it's also important to point out that these are stages of the X-ray, and they refer to patterns of disease on the X-ray, but they don't refer to stages of the disease. So stage 1 X-ray is not stage 1 sarcoidosis. A stage 4 X-ray is not stage 4 sarcoidosis. And if you're a purist like myself, it's inappropriate to say that somebody has stage 4 sarcoidosis. You would say that somebody has sarcoidosis with a stage 4 X-ray. So I'm going to transition here and discuss 2 clinical cases just to highlight some important points that always come up in sarcoidosis. This is a 34-year-old white male, no past medical history, brought to the ED after a motor vehicle accident. The physical exam is benign, the blood work is normal, the ECG is normal, chest X-ray shows bilateral hyaluronopathy. The patient is sent home, and then 2 weeks later comes to your office. And how should you manage this patient? Should you biopsy this patient to confirm that they have sarcoidosis? That's the age-old question. So you may or may not know that the American Thoracic Society produced these guidelines in 2020. It was called the Diagnosis and Detection of Sarcoidosis, and they took up about 9 or 10 PICO questions. And one of the PICO questions they asked is, should a patient with asymptomatic bilateral hyaluronopathy be biopsied? Is it worth determining whether they have sarcoidosis? And this has been a debate for a long time. And I was fortunate to participate in this endeavor. And I can tell you there was a lot of back and forth about what to do here. But in the end, we looked at 75 studies, 16 of which we kept because those were patients with suspected radiologic stage 1 sarcoidosis, 556 patients. And we looked at the outcomes of biopsies, and 85% had sarcoidosis, 2 had an alternative diagnosis, and 11% were non-diagnostic. Of the 2% that were alternative, 38% had TB and 25% had lymphoma. And, I think it's important to point out that while it's a relatively small percentage, it's, not a good thing to miss lymphoma. And this is always the concern for any person who is worrying about not biopsying a patient with asymptomatic bilateral hyaluronopathy. So what did the group decide? Well, after a lot of hemming and hawing, we basically decided that the decision should be made on a case-by-case basis. And that was a conditional recommendation of very low quality evidence, because you can see we didn't have great quality studies here. And they also added, we also added in the comments section that a lot of what to do depends on, 4 or 5 different factors. And that relates to the regional prevalence of alternative infectious etiologies. So if you live in the Midwest and you're worried about histo, you might be more inclined to biopsy someone. If there is any concern about malignancy or recurrence of malignancy, in other words, the patient has a history of malignancy, then it might be worth doing a biopsy. What's the procedural risk? Well, if we're talking about EBUS, the procedural risk is quite low. If we're talking about mediastinopscopy, then the risk is higher. So that has to be factored into the decision. And what about follow-up? Are you dealing with a patient that's going to come back and show up and, listen to the results, and you're going to be able to monitor them to see if you decide not to biopsy them, that they don't develop symptoms concerning lymphoma? Or are you dealing with a patient that is very rigorous and is going to show up and, you're not worried about taking off? It might be reasonable in a patient that is going to follow up to just sit on it. And then, of course, patient preference matters, right? Some patients feel that an EBUS is a really significant, sort of almost surgical procedure, whereas others feel that it's really closer to being a colonoscopy. It's ambulatory, the risks are quite low, and they don't have a problem, doing a procedure to confirm their diagnosis. Other patients want to know if they have something or they don't. A separate group of patients will say to you, hey, if it's not going to change what you do, you're not going to treat me. If I just have hyaluradenopathy and you know that I have sarcoidosis, then why do I need to get a biopsy? So I think all of these arguments come into play. And I think that, it really is something that must be considered on a case-by-case basis. So cardiac sarcoidosis case, 47-year-old African-American female, biopsy-proven sarcoidosis, comes to your office. She's asymptomatic, normal physical exam, normal and stable pulmonary function. Chest X-ray shows bilateral upper lobe interstitial infiltrates, which has been stable for the past 2 years. She's concerned about cardiac sarcoid. That is, she has sarcoid, she has proven diagnosis, but she's worried that she might have cardiac sarcoidosis. Should she undergo screening for cardiac sarcoidosis? And if so, how? So before we answer that question, just a few background facts about cardiac sarcoidosis. The prevalence is somewhere around 10 to 20% of all patients. If you've been studying sarcoidosis for a long time, you'll know that 10 or 15 or even 20 years ago, cardiac sarcoidosis was thought to be extremely uncommon, less than 5% of patients. But they started, when they did autopsies on patients, they found that 25% had granulomas in their heart. And now not all of those 25% exhibited overt cardiac disease, but we knew that we were missing patients in terms of the diagnosis. And now that we're looking more, that we have more advanced testing, we're finding that cardiac sarcoidosis is more common than we once thought. The most common clinical manifestation of cardiac sarcoid is AV block in about 45% of patients. Subclinical disease is a big deal in cardiac sarcoid. About 30% have subclinical disease. And more importantly, about 30% of patients with cardiac sarcoid undergo or experience sudden cardiac death. And that can be scary because if the sarcoid is subclinical and then there's a third of patients having a chance of experiencing sudden cardiac death and you don't see the cardiac sarcoid and the symptoms, it really begs to question, how should I sort of screen for this? As you may know, endomyocardial biopsy is a very insensitive technique for diagnosing cardiac sarcoidosis. And as a result, really the practical standard of care, the diagnostic standard of care, is advanced cardiac imaging tests, such as cardiac MRI and cardiac PET. And these are two images there. The image on the left is enhancement, late gadolinium enhancement on cardiac MRI, and the image on the right shows FDG uptake on cardiac PET. So we asked the question, how should patients with biopsy-proven sarcoidosis, no signs and symptoms of cardiac disease, be screened for cardiac sarcoidosis? And there were 1,200 or so studies. 13 studies looked at various, really what we did is we looked at various test techniques to diagnose cardiac sarcoid, and 13 of them dealt with the ECG, 30 dealt with the echo, and 6 dealt with the Holter. And then within the ECG category, 4 studies were acceptable. demonstrating and showing that in ECG had a sensitivity of 9% and a specificity of 97%. TTE, there were 2 acceptable studies, and TTE had a sensitivity of 25% and a specificity of 95%. And then 2 studies for Halter, which had a sensitivity of 50% and a specificity of 97%. So you may look at these data and say, wow, this is really bad data, tough to answer the question. And the truth is, you're right. It's very difficult to answer this question because of the limited amount of data. And, no studies compared any of the tests to no testing at all. None of the studies that we looked at were randomized. Patients were symptomatic or asymptomatic, but no mention of the actual symptoms. And only one study evaluated all 3 tests in one population. So the data was really limiting here. And it made it difficult to sort of come up with an overall recommendation. I think you could see from the data that none of these tests is sufficiently sensitive to be a good screening tool. But the ECG, for example, has very high specificity. So if you have a patient with sarcoidosis and they get an ECG and it's abnormal, that should really prompt you to go on to doing additional testing. But in any event, what did we decide? Well, we decided that ECG is really the recommended screening tool. Why? Because it's non-invasive, it's readily available, it's inexpensive, and it's recommended in all patients. Of course, it was a conditional recommendation of very low quality evidence. We also recommended against using the TEE and the Holter combined because the combined sensitivity is less than 65%, which is not a good screening tool. That too is a conditional, very low quality evidence. So screening for cardiac sarcoidosis is a tough issue. What I will say is you've got to take a good history, and anyone who has palpitations, chest pain, low extremity edema, dizziness, anything that supports a cardiac diagnosis should go for additional testing. But again, these were in patients who didn't have any of those symptoms. So what about prognosis in cardiac sarcoidosis? How can we prognosticate and tell patients about what their risk of mortality is, what their risk of future events? Well, it turns out that there are a couple of pretty well-established risk factors in cardiac sarcoid. And on the panel on the left, you can see that there are Kaplan-Meier curves that look at various historical facts in the patient's cardiac history. So for the A panel there, you see the presence and the absence of heart failure. Obviously, if you have heart failure, you have a higher risk of transplant-free cardiac. If you don't have heart failure, you have a lower risk of transplant-free survival. If you have an ejection fraction greater than 50%, your mortality or your risk of transplant, your mortality is higher, your risk of transplant is lower. Whereas if you have an EF of less than 35%, it's vice versa. New York heart class or functional status also plays a role. The higher the heart class, the worse the prognosis. With respect to the MRI, I talked about this a few minutes ago, late gadolinium enhancement is a risk factor for all-cause mortality, cardiovascular mortality, ventricular arrhythmias, and death or ventricular arrhythmia as a composite endpoint. The things that we look at on PET, perfusion abnormalities and FDG uptake, those two are prognostic in sarcoidosis. This is in cardiac sarcoidosis. This is an interesting table that looked at survival-free death from VT in over time. And what you can see here is that if you had normal perfusion and normal FDG, your survival was highest. If you had abnormal perfusion and abnormal FDG, your survival was lowest. And if you had one of those, then your survival was in the middle. So LGE and perfusion defects and FDG uptake are all prognostic in cardiac sarcoid. So what about sudden cardiac death and cardiac sarcoidosis patients? And, again, I said that earlier that 30% of patients experience sudden cardiac death. And that's something as a physician that you really don't want to miss. And it's quite scary. So, in the last slide, I said that, a history of CHF, the presence of LV dysfunction, late gadolinium enhancement on cardiac MRI and PET scan findings, perfusion and FDG, all of those associated with, cardiovascular mortality, mortality in general, VT, or ventricular arrhythmias, excuse me. But what about patients who don't have any of those things or only have one or two of those things? So, for example, a patient who has no history of heart failure, their left ventricular ejection fraction is normal. They have some abnormalities. They have LGE on their cardiac MRI, but you've done a PET scan and there's no FDG uptake and there's no perfusion defects. What's their risk? And how should you determine what their risk is for sudden cardiac death? So a tool that's evolved over the years to be useful for risk stratification for sudden cardiac death is the EP study. And I'm going to talk about that in a second, but before we talk about that, just look a little bit at indications for ICD, right? If you have ventricular arrhythmias and you have an LV, and you do or even you don't have an LV EF that's less than or equal to 35%, an ICD is recommended, right? And that's class 1, that's primary prevention. If you have syncope, plus or minus a need for a pacemaker, plus or minus inducible VA or ventricular arrhythmias on EP study, then the recommendation is an ICD is useful. That's class 2A, and that's more of a secondary prevention indication. But you may have no symptoms, and you may have an LVEF of somewhere between 36 and 49%, or an RV dysfunction of less than 40%. How do you handle these patients? What should you do? What's their risk for sudden cardiac death? Well, first of all, an ICD can be considered, and that's 2B. But some of it really depends on the MRI. And if the MRI is positive or negative, you might consider doing an EP study. Unlikely you're going to do an EP study in someone who has a negative MRI, because then it would be very difficult to diagnose cardiac sarcoid, right? Unless you had a biopsy with a negative cardiac MRI, but that doesn't happen very often. So most of the time you would have somebody with sarcoidosis who has some sort of symptoms. They get an MRI. The MRI shows late gadolinium enhancement. Their PET is negative. Their function is good. And you want to know whether they need an ICD or not. So you can do an EP study. And in this particular case, if there's no late gadolinium enhancement, you observe, and that's class 3. But if there is late gadolinium enhancement, and there's a scar burden of roughly greater than 6%, it's reasonable to proceed to an EP study. And if the EP study shows that there's no inducible ventricular arrhythmias, then what we generally do here, and it's a fairly accepted practice in most institutions, is to put in a loop recorder. If the EP study shows that there are inducible ventricular arrhythmias, then we put in an ICD, and then we refer back to, secondary prevention, in which it's a class 2 indication. There's been a number of studies that support this algorithm. We actually did a study in 2021. It was a small retrospective study looking at 46 patients. And basically, to cut to the chase, we found that the negative predictive value of an EP study for the development of ventricular arrhythmias, and remember, the patients who had a negative EP study got a loop recorder, so we were able to monitor what happened over the ensuing 2 years or so. Our study showed a negative predictive value of 100%. Ours was higher than other studies, but these are two other major studies that took on this question. And the patient populations were a little bit different. The diagnostic criteria were a bit different. But basically, if you look at this negative predictive value column, you can see 93 to 100%. And we followed our patients for a mean period of about 2 years, where they followed their patients for a mean period of 4 years, 4.5 years or so. So, basically, this is a very, very good tool to be used to rule out risks for ventricular arrhythmias. And the problem is not everybody can undergo an EP study. Not everybody wants to undergo an EP study. So lots of investigators are looking at imaging, cardiac MRI, and PET scan to see if those tools can be used to predict who might develop ventricular arrhythmias, sort of a non-invasive way of predicting risk and of sudden cardiac death, and who needs an ICD and who doesn't. So I'm going to transition here and just talk a bit very quickly about therapeutic targets. This is a complex schema of the immunopathogenesis of sarcoidosis. Suffice it to say that there is an antigen or antigens that that the sarcoid patient is exposed to. They are predisposed genetically to have an immune system that overreacts to the exposure. When the exposure is cleared, the thoughts are that patients develop remitting disease. When the exposure is persistent and not cleared by the immune system, patients go on to develop chronic fibrotic disease. So during the last 10, 15 years, we've learned a lot about immunopathogenesis. And these are all various targets that are being studied or have been studied in sarcoidosis. I'm not going to talk about all of them, obviously. I'm just going to touch on a few. Tofacitinib, which is also known as Xeljanz, it's a JAK-STAT inhibitor, is a new therapeutic target that holds some promise as a proof of concept phase 1 study in pulmonary sarcoid that showed that patients were able to taper their prednisone to less than 5 milligrams daily. A phase 2 is hopefully around the corner. Another key target is CMK389, which is an IL-18 antagonist. And that's a phase 2 study for chronic pulmonary sarcoidosis that's ongoing. There's another drug that is called efzotitimod, which is a neurophilin 2 modulator. A phase 2 was completed. Neurophilin is a transmembrane receptor on antigen-presenting cells and T cells. It's expressed in granulomas. Modulation of neurophilin 2 reduces the immune response. A phase 2 was just completed recently and showed that there was steroid-sparing capacity in about 30% of patients. A phase 3 is planned. And then nicotine is actually enhances T regulatory function. It's also involved in JAK-STAT signaling. And a high concentration of nicotine suppresses TNF alpha, T regulatory cells, Th1 and Th2 immune responses. A phase 2 in pulmonary sarcoidosis was completed. There was a 2% increase in FVC percent predicted, and a phase 3 is planned. I've talked about tofacitinib, and then the last thing I want to talk about is the mTOR inhibitors. The mTOR pathway has been really, people are really excited about in sarcoidosis. And these are just images of before and after treatment with rapamycin in a patient with pulmonary sarcoidosis. And you can see A compared to C, there's significant improvement. B compared to D, significant improvement as well. People ask me all the time about fibrotics, antifibrotics, and we're sort of getting a little short on time. So just to cut to the chase, we don't know the answer to that yet. The InBuild trial had about 12 patients, 2%, who received nintedanib. And we really don't have any data to determine the efficacy of these drugs yet. I can tell you I've used them in 2 patients of mine. One is holding her own. But I would say at this point, we don't have the data to support the routine use of these antifibrotics in patients with fibrotic sarcoidosis. The last thing I want to discuss is drug-induced sarcoidosis. Why? I included a slide on this topic because every day there are new drugs that are coming out that cause sarcoidosis-like syndromes. I just want to point out that the literature has really sort of played around with the words associated with sarcoidosis-like syndromes. I think for simplicity's sake, and I can answer questions on this later, it's important to understand that we should probably call these drug-induced sarcoid reactions instead of sarcoid-like reactions, which has typically been the terminology used for granulomatous inflammation associated with tumors, but's morphed into describing drug reactions in sarcoidosis. There's a bunch of different medications that cause drug-induced sarcoidosis. Usually when you stop the medication, the syndrome or the presentation improves. In some cases, you do need to use anti-sarcoid therapy or anti-inflammatory therapy. Usually drug-induced sarcoidosis occurs within the first 2 years of diagnosis. So just to quickly conclude, sarcoids are a worldwide disease with geographic variation in incidence and prevalence. Genetic factors play a role in susceptibility in the clinical phenotype. Obesity and weight gain are risk factors. Environmental exposures are implicated in disease pathogenesis to a varying extent. Clinical manifestations are dependent on age, gender, and race. Biomarkers are not available, or at least sufficiently available. The decision to biopsy should be made on a case-by-case basis. Sudden cardiac death is something serious in cardiac sarcoid, and you can use EP study for risk stratification in patients who have normal or mildly impaired left ventricular ejection fraction. And finally, new therapeutic targets have been identified, particularly the mTOR pathway. Drug-induced sarcoid is increasingly common, but the mechanisms are poorly understood. I really appreciate everybody's time today, and I'm happy to answer questions.
Thank you so much, Dr. Morgenthau, for that incredible talk. So much to take away and learn and bring awareness to sarcoid. We do have a couple of minutes left, so I think we can take a question or two, either in the chat or you can unmute yourself and ask a question. I actually had a question, Dr. Morgenthau, if no one's speaking up. So regarding the climate effect on diagnosis of sarcoid, I know you spoke about, different regions, and I was wondering, is there a correlation? I've read articles that said that coldest climates usually have I think the earliest diagnosis of sarcoid, and then, but varying summertime regions and areas that have warmer climates have later onset of sarcoid diagnosis. Do you think that has to do more with the bias that comes in the cold time? We have more exposure to diagnostic imaging like chest x-rays and the prevalence of URIs, and then the incidental findings that may point to sarcoid? Or do you think there's more of a pathophysiologic explanation for why climate changes and regions with various climates have differences in earlier or later onset or diagnosis of sarcoid?
Yeah, I mean, I think it's an interesting question, and I'm not sure I know the answer to it, but I think that, people have always posited that, sunlight and vitamin D plays a role in sort of activating sarcoidosis, or, is implicated in that pathogenesis. I think, others have thought that, maybe when you're outside more in the springtime, one argument is that you're exposed to more stuff outside and you can inhale that stuff, and that's, some sort of trigger. Other people would say, hey, well, it's really what you're exposed to on the inside that, might expose you or trigger something related to your sarcoidosis. So being inside in the winter months might be worse, but I don't honestly think that we really know. And I think, one of the things we didn't talk about today, because there's not a lot of data, is epigenetics in sarcoidosis. And there's some work being done to look at epigenetics, right? So the influence of the environment on the genes. So, you have genes that predispose to sarcoidosis risk, and then you have individual environments that influence those genes that are of risk. And that's, something that's, I think, really interesting. And again, I think it's going to depend a bit on, the context of exposure, the timing, the duration, and the gene that we're actually talking about. So I think it's a really complex question that we don't know the answer to right now.
Thank you so much, Dr. Morgenthau. I think we have a question for from Dr. Willie B in the chat. I have a patient with a pituitary adenoma that turned out to be sarcoid, and what is the incidence of a neuropresentation of sarcoid?
Yeah, so neurosarcoidosis was always thought to be on the rarer side, and we continue to believe that it's on the rarer side. In general, it's probably about 10% of all patients with sarcoidosis, but then you get into sort of nuances of what type of sarcoidosis are you talking about? Are you talking about CNS disease as opposed to peripheral disease? And then within the peripheral disease, are you talking about regular neuropathies like large fiber neuropathies or small fiber neuropathies? But in general, probably about 10% of patients with sarcoidosis have neurosarcoidosis.
Wonderful. Thank you, Dr. Morgenthau. It is 1:02, so I want to be respectful of everyone's time, including Dr. Morgenthau. But thank you so much for joining us for this incredible lecture. It was a pleasure learning from you, Dr. Morgenthau. Thank you, everyone.
Thanks for having me.
Of course. Have a great day.